Thank you for inviting me to present a lecture about MR neurography technique. According to the ISMRM guidelines, I have nothing to declare. Since these online lectures are quite anonymous, I would like to give you a quick overview. My name is Andreisek. I'm a professor of radiology. I consider myself a general radiologist with a focus on MSK and MR imaging. I'm the co-director of a decent department where we run about 10 MRI machines in parallel every day, so we do see some cases. In case if you're asking yourself where I'm located, well, I'm located in Switzerland near the border to Germany. So wherever you are right now in the world, I'm in Europe on this yellow spot here. We consider peripheral nerve imaging as a dedicated exam for imaging the nerves. So we created a couple of years ago the term MR neurography, which we use also in our reports to make clear that it's a special examination and not just a normal MRI of an anatomic region. There is a huge need for imaging of peripheral nerves. First, the incidence of neuropathies is quite high. For example, 5% of the population has some form of a neuropathy, and even 5% of the trauma patients, they have a peripheral nerve injury. So there is quite some cases around, and MR neurography has evolved as a problem-solving tool in many difficult cases, and also in some indications in a clinical routine as a routine exam. This fact is related by our numbers in our department. As you can see, there is a steep increase in annual examination numbers, and we have everyday exams going basically from the head to the peripheral nerves in the extremities. We have dedicated protocol for each of these anatomic areas, as you can see here, and they are basically run in a standard routine fashion without interaction of any doctor once it's protocoled and once the indication is clear. There is some exceptions, and I will talk about this later. The best situation is if you have really good referrals from your referring physicians. This does not come by itself. In most cases, you have to educate your clinicians so that they select the patients properly, which need to undergo or should undergo MRI. If you take every patient, you will not get good results, and the technique will not become as effective as it can be if you select your patients properly. You have to ask your referring physicians that they limit the field of view for you. Basically, they need to make sure that they already have examined the patient before and that they know what they're looking for, so that you can focus on a specific anatomic region and not have to look for the whole leg, for example. This takes time and usually results in an insufficient diagnosis. The best is if the clinician or yourself are using pre-MRI ultrasound to narrow down the differential diagnosis and to focus the MRI exam. So my recommendation is focus, focus, focus once you get your referrals. In my hospital, I work with a team. There is a plastic surgeon, there is a neurologist who is specialized in peripheral neuropathies, and then there's myself. So we have a team, and this team is working very closely together on a daily basis. And that's maybe an ideal situation you should reach. Let's go to the imaging part. For didactic purposes, I always distinguish between these anatomic non-selective imaging sequences and so-called selective imaging sequences. These non-selective imaging sequences are basically normal T1, T2 fast-spin echo sequences, maybe even 3D sequences like the space, vista, or cube, as it is written down here. They have in common that they provide the best resolution as possible, and they should be, whenever possible, acquired in an isotropic acquisition, so that you can do multiplanar reconstructions afterwards if needed. It's mandatory that you use the best equipment you have, because you need a lot of signal out of the anatomic region. So the better the signal, the better the images, the better the diagnosis. So put everything on the patient you have in terms of field strengths, coils, and parameters and sequence techniques. Nerve selective imaging means that you focus on the nerve specifically, which means you use sequences, MR sequences, which can highlight the nerves and suppress the background signal. You can see this on this example image here. On the left side, you see a normal sequence. On the right side, you see a sequence where the background signal is suppressed by special techniques. In this case, there was a diffusion pulse used to suppress the vascular signal around, so that you can really work out and to see the nerve only, and that is an ideal situation. Depending on the different manufacturers, there are different techniques available, but they can help, and you can avoid misinterpretations by nearby vessels or other bright structures. So first conclusion, use proper technique. Standard sequences turned out to be really very helpful. I always recommend that you go transaxial to the length of the nerve, so that you have a nice cross-section image of the nerves in the periphery especially. So I use a lot of axials in the extremities, of course other planes as well. But yeah, you can see that the normal protocol is pretty straightforward. I do give contrast, but only in selected cases where I want to see if there is a breach of the blood-nerve barrier and if there is enhancement or inflammation of a nerve. In addition to the best equipment you should use, you should also train your technicians that they position the patient properly in the isocenter of the magnet. You have to play around which position for the patient is the best, considering that they have pain in most of the cases. You need to use a lot of fixing devices, sandbags, and whatever you can get to keep the extremity without motion, because the nerves are usually very tiny. If you have motion artifacts, you will have difficulties to make a good diagnosis. So all these around settings are very important to improve image quality, and do not underestimate this. You really need to work together with your clinicians to have the setting around the patient set up very, very carefully and accurate. Let's talk a little bit about coils, because it's not a secret that the best coil will give you the best signal. However, there are new developments. For example, dedicated multi-channel coils. Of course, they are on the market for quite some time, but there are also dedicated coils which you can basically these days wrap around the patient, so that you have really the coil very close to the anatomic region of interest. Especially these air coil techniques are now available from different vendors, also Siemens, not only GE, but also other independent vendors. They sell them. They are really feasible that you wrap around them around the body, and you get close to the nerve you want to see. I have seen tremendous improvements in image quality after we started using these kind of coils. Depending on the manufacturer, they also provide you with new type of sequences, such as this one, which is basically a product from Philips, but also similar sequences available from other vendors. Those sequences are usually based on the fact that they try to suppress the fat signal from the surrounding tissue as much as possible using different kind of techniques. In this case of this sequence here, it's a spare pulse. They also try to suppress the vessel signal. In this specific sequence here, there was a technique used which is called IMSDE, and overall, all these sequences are usually T2 weighted or heavily T2 weighted sequences, so that you can see really the nerves bright against a dark background. Using state-of-the-art imaging and equipment will give you image quality which is already very, very good these days. For example, here you can see a coronal plexus sequence, very high resolution, very nice suppression of background signal. This is taken from the daily routine program at our hospital, so you can see really excellent image quality with our current standard equipment. Another example is this one here, also taken from one of our patients. You can see this is a stunning image quality of using a diffusion sequence for the plexus. Very nice. Of course, this was a 3 Tesla machine and a high-end coil, but it was not. It is all commercially available, so it's really daily routine what you can achieve here. I personally do not do a lot of diffusion sequences in my protocols. Those are mainly reserved for special patients, or if we do some research exams in addition. But if you do it, you can have really nice overlays of anatomic images as well as functional images, as you can see here. Standard 3D software will allow you to superimpose those acquisitions, and you will get such nice color-coded images. However, for me, in the clinical routine, it's much more important that you really get good anatomic images, such as this one. We use 3D reformats, either online or offline, to really get the best out of these sequences, and to really have all nerves viewed in different planes. As I have said before, I like transaxial images of the nerves, and I even do this in the plexus, as you can see here. What I really like is sagittal images, so that you can compare the left and the right side of the cervical plexus. And I only speak now about the cervical plexus. So for me, it's very important to always have transaxial images. Here you can see an example. What I mean, you have the left and the right side of the plexus, and you can see the nerves very nicely here as as bright spots, and you can compare left and right hand side quite easily. This patient, by the way, had a classic sign for traction injury. I quickly mentioned before that in a certain percentage of cases, I personalize the examination, which means that I'm at the MRI machine, present in person personally, and supervise everything the technician does. This is quite time consuming, especially if you have several patients a day, but sometimes it's really necessary to adjust the planes, to work out the best from the exam, especially in very tiny nerves. Um, so you cannot expect from your technicians that they know everything. You need to be present in a certain percentage of cases. I will not cover functional nerve imaging in this talk because for me in the clinical routine it's not really important. I do it from time to time, select cases, but it's not part of our routine imaging protocol anymore. So, summary, how I do it. Well, I use my best scanner and the coils. I tailor protocols. I have standard protocols, but I also personalize them if needed. I have taught our staff everything about what I know about anatomy, and I have my standard MRI sequences which I use always, and this yellow box here I only use very rarely in the clinical routine. Some words maybe apart from the technical aspects, it's also important for yourself to train yourself. You need to know the anatomy of all those nerves. If you don't know them, you have to look them up. It's not a shame. Even I do it frequently, and I also recommend it to my fellows and residents that they always look it up, especially the smaller nerves. They have also variants, normal variants, anatomic variants, which are not that obvious. So it's always good to compare and to be really sure that they have no pathology, and that's these e-anatomy and atlases are really very helpful for. An interesting aspect of the nerves, especially of the larger nerves, is that they also have contribution from different nerve roots. And this contribution can be seen, especially in the sciatic nerve, from the pelvic region down to the knee. If you, for example, perform an exam of the sciatic nerve, let's say in the mid of the thigh, you can really differentiate those parts of the nerve which were originating from the L5, S1 or S1 nerve root. You even can have pathologies of a part of the sciatic nerve, as you can see here in this publication. And that's very important that you know also the microanatomy or the fascicular organization of those peripheral nerves, especially in the leg. It's very helpful that you try to distinguish it. Of course, you need to have good high resolution images for that. Another learning curve concerns the diseases you will be faced with. They are sometimes quite rare. They are maybe even new. For example, these days we have a lot of coronavirus associated neuropathies, and so you need to be on the top of those diseases, and you have to know them, especially the rare ones. The hereditary ones, they are not so frequent, and so you need to have a good knowledge about these diseases. Similar to that, you have to know sometimes strange kind of surgeries. You would be amazed what the plastic surgeons can do these days. They transfer nerves, they connect the nerves differently, and if you get a postoperative image such as this one, this was a so-called overlean surgery. Uh, um, then you're faced with a completely altered anatomy, and you will have no chance at all to make a diagnosis in these postoperative cases if you have not read the surgical report properly and precisely, because you need to know what which nerve they connected to another. So otherwise you're completely lost. The nerve is not the nerve only. If you perform neurography, you also have to look on the end organ of the nerve, and that's very often that is the muscle. We have the neuromuscular junction. They can have their own diseases, but whenever you look at an MR neurography, you always look on the nerves and the muscles. That's very important to remember. So MR image interpretation is all about knowing the anatomy and the nerves. You need to describe the abnormalities precisely, and then you have to look for the muscles if they are hyperintense or if there is atrophy of the muscles already. I always recommend, uh, not only in the MR exams, MR neurography exams, but in all my reports, I recommend that you use a structured report. So give your report some kind of structure, keep it simple, and keep it always the same structure. So you don't miss anything. You will train your referring physicians to read it, to understand it, and to get a feeling what you mean. That's very important. I would like also to recommend that you make the diagnosis visible to the clinicians in an easy way. So in our hospital, it's normal that we draw errors on the images, makes snapshots of the important diagnosis so that clinicians don't have to scroll through hundreds of images. A very unique way of presenting images is using these cinematic rendering techniques, which is provided by some vendor software. This picture was taken from a publication from Jan Fritz, and it's very impressive, I think. With this, I would like to conclude my presentation and would like to thank you very much for your attention.